Testing, testing. Can you hear?
Yes. Yeah.
Oh, yeah. Somehow that's, oh, you're right. It is 23. I think we might page 24, and so I thought, oh, the request number. So it's request number 23. I apologize. I don't see Harrington. We do, yes. Just to let you know who's not here. Yep.
You good? Ready, sir?
You good?
You good, all right.
Sure. Oh, I just like it.
To begin, I'd like to entertain a motion to allow Director J. Bott. Oh, I'm sorry. Roll call. It's all right. Never mind. There you go. There you go. I'd like to call, the meeting of the board to order. Will the secretary please call the roll?
Director Bott?
Here.
There you go.
Director Curry? Vice Chair Deere?
Present.
Director Garza is absent. Director Harrington is absent. Director Ryder is absent. Director Robinson?
Present.
Director Sorrell? Director Story?
Present.
Director Webster Cross? Present. And Chair Taylor?
Present.
You have a quorum.
Thank you. Next, I'd like to entertain a motion now to allow Director J. Bott to, remotely participate in this meeting as a voting member.
So moved.
Second.
The motion has been made and seconded. Is there any discussion on the motion? If not, all in favor?
Aye.
Aye. All opposed? The ayes have it, the motion carries. Thanks. First on, today's agenda is employee recognition, which will be reviewed by Ms. Valerie Amos. Ms. Amos.
Good morning.
Morning.
This is Valerie Amos, Chief Human Resources Officer. So I'm pleased to share, we have some leadership individuals who started with us. Please welcome our new hires, Christine Abadila. She is the Surgery Quality Data Manager for Surgery Administration. Sadia Carter, who joined us as the Superintendent of Police and Security. Joseph Francois, the Budget Director for Finance. Marley Hendricks, who's our Director of Public Health Administration. Everett Hobson Johnson, who's our Nurse Coordinator 2 and Coronary Care Unit. Next slide, please. LaWanda Holmes Williams, who's our Grant Administration Manager for ARPA in the Behavioral Health Department. Peter Sussy, who's returned as our Director of Patient Flow and Nursing Administration. Jay Shah, who's our Pharmacy Medicaid Program Manager for County Care. And May Zhang, who's our Associate Director of Nursing Medicine Nursing Administration. Next slide, please. We have some promotions. Helen Agoma, who's our Director of Utilization and Case Management for Care Coordination. Lynn Dotson, who's our Nurse Coordinator 2 of Patient Care Services. Albert Osei, who's our Medical Director for Research and Clinical Trials. Dewana Parama, our Manager of Provider Network, Contracting and Health Plan Services for County Care. And Dr. Pierco, who's now our Associate Chair of Medicine, Clinical Service Integration for Medicine Administration. And Dr. Chad Zawitz, Chair of the Division of Correctional Health. So please join me in welcoming and congratulating all of our promotions.
Welcome, congratulations. Thank you. The next item on is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted on the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual testimony or submitted written testimony?
We did not receive any registrations nor any written testimony.
Thank you. Before we move on, I'd like to acknowledge Director Harrington. Thank you. Next on the agenda are board and committee reports. The minutes of the August 25th board meeting are being presented for your approval. Are there any corrections or revisions to be made to the minutes? Hearing none, I'd like to entertain a motion to approve item 4A, the August 25th board meeting minutes.
So moved.
Second. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? The ayes have it. The motion carries. Next, Valerie Amos, you didn't go too far, I hope. Thank you. We'll now review the human resources metrics. The committee did not meet this month, so the metrics are being presented directly to the board. The next meeting of the Human Resources Committee will be held on Tuesday, November 9th at 12 p.m. Ms. Amos.
Good morning again. Morning.
Yeah, it's all in
Whoa, okay. All right, let's sing together. So I'm pleased to share from December 1st, 2022 through August 31st, 2023. Here's our hiring metrics. We extended almost 1,400 offers during that time frame, and over 1,000 individuals did accept our offers. So that particular number, 1,059, does include both internal and external offers as well as our promotions. So we're very excited about that. To the right, you will see that 660 of the 1,059 are external hires. So we have now exceeded fiscal years 2018, 19, 20, and 21 in terms of our offers as well as external fields, and we have not completed this particular fiscal year. Our net new gain for this year is a bit over 200, so 211. We still have a fairly decent offer acceptance ratio of 78%. Ideally, we'd love it around 80%. But as you can see, 305 individuals did decline our offers for a variety of reasons. But we are continuing to track and trend, and we are competitive in the market and moving the needle even faster. In terms of time to fill, our goal is 90 days. So that's from post to acceptance, and we're about at 91 days. So we trickled up a little bit, but we will continue to trend that particular metric as well. Next slide, please. So here's another depiction of our hires. These are actual individuals who have started. These are real employees. So the previous slide showed all of our offers that had been accepted. So that number was 1,059. So as you can see on the top bar, FY23, 1,019 individuals have started with us or who have moved into their positions. So as you can see, year over year, we have outpaced 2 previous years. The bottom graph depicts the externals versus internals, and again, we have outpaced those particular years as well. So these are individuals who have started quarter by quarter. Very pleased. Next slide, please. In terms of our turnover and separations, our turnover metric is about 7.9, so we are seeing it increase a peak, but again, we have a tenured workforce, and we've talked about that at previous board meetings. So we are continuing to forecast that metric and identify how many individuals who have met that retirement age as well as the accrued pension and could, retire at any point in time. So we will continue to monitor that, but we are well below the national benchmark, and I'm proud of that. Next slide, please. Here are separations. So 449 individuals have separated from, again, December 1st, 2022 through August 31st of this year. As you can see up top, we are still, trending lower than the previous years, but we realize that that remains a challenge with the tenured workforce. In terms of the top couple of reasons, retirements and resignations are listed below. As mentioned before, the retirements are peaking up a bit. The resignation numbers have gone down, so we're pretty proud of that, and we hope that the retention bonus that the Board of Commissioners, as well as you guys approved, is making a fundamental difference there. Next slide, please. Turnover is depicted, again, we talked about 7.9 overall, and as you can see, quarter by quarter, year after year, those stats are listed there. So we are trending down in terms of the year-to-year comparison, but we still have the last quarter to go, so we will continue to monitor that. Next slide, please. Pre-pandemic information. So I think the slide, we placed the slide in so that you could see how pre-pandemic versus post-pandemic was affecting our workforce. And as you can see, we are still looking to trend downward, but pre-pandemic numbers were much better, 5.6, 6.8, and so forth. So we recognize that this has happened over the workforce, throughout the nation. So we will continue to work hard at retaining our staff. Next slide, please. In terms of recruitment activities, just wanted to share some highlights. We started a nursing accelerated hiring process, and my colleague who's in the room, Kim Kraft, who shall stand, please, our employment plan officer, who's going to provide her report. Of course, we don't do everything right in HR. We try our best. But most importantly, Kim and I and Drew Juster, stand please, our program manager. There was a huge collaboration between the employment plan office, the Office of HR, as well as our nursing department, Dr. Bina Peters and her team. So we got together and we discussed an accelerated hiring program. And so fundamentally, we launched a 30-day pilot where we wanted to recruit a large number of externals. And there was planning involved, there was marketing. Alex Normanton, who's here, our interim chief marketing officer, everyone got behind this campaign. And so we wanted to do something fundamentally different. We pulled together nursing profiles. So departments, we wanted to identify certain departments. So we identified 8 departments. We looked at those departments and said, we tend to have quite a number of applicants. If we can just shave time off of our entire time to fill process, let's do something fundamentally different. And so we got together. We have internal recruitment scripts as well as meet and greet options, but most importantly, we were able to identify a number of external nurses who applied to positions. We validated that they were minimally qualified, and then we, in HR, called them and extended an offer. So we were trying something novel and different because we knew that we needed to accelerate the nursing hires. And so I am pleased to share on the next slide the results, but we streamlined that process to once someone applies, then they automatically receive an offer after we have validated them. And so many candidates, as you can see on this slide, We extended 120 offers in 30 days, and this was all to nurses, to internals as well as externals. 81 individuals accepted. 9 individuals were pending. We had extended those offers, and they had not accepted at the point of this slide, and then 30 individuals declined. And the breakdown even further, 53 of the 81 were externals, 28 were internals. And so I have the numbers as of today. We have now extended beyond the 30-day pilot, 152 offers. 98 people have accepted, and of that 98, 67 of those are externals. So we're extremely excited to share that people really are attracted to Cook County Health, and so just sharing more information about the department. So the nursing department, again, those unit profiles outlined, patient populations, you know, the ratios, all of the information that they would normally hear in an interviewing process. They heard it from the recruiters. So we pitched the position. They accepted the position immediately, or some wanted to think it over. And then once they accepted the position, we were able, the nursing department set up meet and greets for them so that they can come in and tour or talk with them, or just have virtual discussions so that they can get their questions answered. So we attempted this approach. It was hugely successful. We will monitor those new hires as they continue to onboard to ensure that they are staying with us, you know, beyond probationary period, beyond the first years and so forth. So in terms of stats, we had a 67% acceptance rate in this 30-day pilot. 80% of the candidates who applied were eligible. They were minimally qualified, because often I will stand up and say, if people are not qualified, we cannot hire them. And then we had a 24% declination rate. So we have some lessons learned to the right. I won't read all of those, but we're gonna hopefully market, you know, even stronger. So Alex and I have already talked about that, to extend that marketing campaign. Our sourcing strategies are stronger, and we just learned a lot. So we're excited about that novel approach, and I do want to thank, again, Kim Kraft and her team, as well as Dr. Bina Peters and her team for collaborating with us, and of course the HR recruiters who really hunkered down. We had a dedicated team of HR nurse recruiters who extended these offers, as I mentioned, in record time, within 30 days. So thank you to everybody.
Well done, well done.
And then Debbie, if you go back one slide, the second portion of this slide talks about the time frame for the pilot. It was from August the 7th through the 15th of September, because we needed that promotion time. We had to post the positions and promote it before we removed those postings, and then validated those candidates, which, you know, added a week or so. The September job fairs were well attended yesterday. That marked our 45th job fair in 2 years. So I'm very excited and proud to say that, you know, we had a number of good candidates from the nursing, radiology, and pharmacy job fair. I don't have all of my stats in front of me, but we had a well-attended event yesterday. So I will take questions if there are questions.
Just out of curiosity, do you know what the acceptance rate was for external people that went through the longer process? Ballpark.
You know, we blend those acceptance rates, so I talked about 78%. We can pull that out. No,
I'm just curious.
I think that that's a good question. We can tease it out, and I can share it with Debbie, and she can share it with you. But the acceptance rate for this program, people were accepting right away. They were excited. There were a couple of people who said, "Are you for real? Are you calling me to extend an offer?" So, yeah, we had a great number of individuals who accepted after the first phone call. So pretty excited about that, but I don't have the stat with me.
Do you know if they fell into the gap where it's harder for us to fill?
Any nursing position, I think, is a notable hire for us. We did identify 8 departments. Some of those 8 departments were very complex, and some of them were a little bit more mainstream, you know, where we do see quite a number of candidates. So we have a good mix. we have a really good mix. And we started small to ensure that, again, if candidates had specific questions that our recruiters were not able to answer, we wanted to tweak those internal scripts so that everyone said the same thing and followed the same process. But yeah, we're pretty excited about how well this has taken off.
Final question.
Mm-hmm.
Do you feel as though travel nurses, the allure of becoming a traveler, is it starting to turn?
We have been seeing a number of the agency staff attend our job fairs. We have been deliberate, proactive, intentional about sharing our job flyer information, not only with you at the board, but also all of our employees as well as our agency staff. We even worked together to craft an agency nursing newsletter. It was an invitation for them to really see the benefits of working here at CCH, and so it was a collaboration between, of course, marketing, Mr. Rocha, myself, and Dr. Peters. So every agency nurse that comes in receives his letter, and so we put together this campaign probably over a month ago, maybe. So we've been seeing a number of agency nurses also interested in our vacant positions, as well as all other agency staff who've been here.
Thank you.
Mm-hmm. Thank you.
Very good, very good.
No, I'm excited. Thank you. Other questions?
Well done. Thank you.
Thank you.
Positive update.
Thank you.
Next, Director Curry and Aaron Galena will now review the Managed Care Committee meeting metrics. That committee did not meet this month, so the metrics are being presented directly to the board. Ms. Galena, Director Curry.
Yes, good morning.
Good morning.
As the chairman mentioned, the Managed Care Committee did not meet this month. Our next regular meeting is scheduled to be held on Friday, October 20th at 10:30 a.m. The committee is due to present metrics today, so I'd ask Mr. Aaron Galena, Chief Administrative Officer for Health Plan Services, to review the metrics.
Thank you,
No
Director.
motion, I'm sorry, my one little thing to do here, no motion is needed. The metrics are presented for informational purposes only.
Thank you.
Thank you, Director Curry. And good morning, directors.
Good morning. Good morning.
We'll start with our membership numbers today. This is as of September. We're right at 450,000 individuals. Of course, our redetermination process has started, and we'll talk more about that in a couple slides. This next slide shows our market share data. This data is now through June. You can see the market's held relatively steady. We're at 32.4%, still the largest plan in Cook County. And then the rest of the market has also stayed relatively steady, as you can see here. The next slide shows our trends versus the overall Cook County trends. These have continued to stay very consistent. Our growth has tracked that overall growth in Cook County, pretty much at a scale level. So it's stayed pretty consistent really for the past 2 years now. The next slide shows our membership versus budget. You can see red bars are actuals, blue bars are our budget. We're continuing to significantly exceed our budget. Of course, as this rolls forward, we'll start providing an updated slide with the fiscal year 24 budget. And you'll see, the revised estimates around redetermination at that point. But again, we assumed that redetermination would start earlier this year than where it ended up starting in actuality. So we've seen continued strength in our overall membership numbers. So this slide shows some information about redeterminations. There's a lot of information on this slide, but if you look at the table on the right-hand side, you'll see the monthly member count. That's the count of individuals that is going through redetermination or is estimated to go through redetermination each month. Then you'll see Form B members and Form A members. Form A members are those that automatically renew, so they don't have to submit information back. Form B members are those that have to take an action, fill out paperwork, and submit that information back. So you can see, the amounts vary month to month, so there is some fluctuation. It's not perfectly even across the 12 months, but generally speaking, you know, we see somewhere between 15 to 25,000 individuals each month that are going to be going through the redetermination process, that are going to have to actively fill out their information and submit that back. The next slide shows some initial data. This shows the number of individuals from our initial cohort that was going through the redetermination process that actively responded to the redetermination paperwork. So we had 90% of our members filled out the paperwork and responded back to the state, which is, I think, overall a really strong result. That was the highest result among all of the MCOs. Of course, this does not necessarily mean that they retain coverage. Some of those individuals may, you know, not have qualified because of income changes or other reasons. But this is really the key factor that we can influence of, can we outreach to them and help them through the process of filling out that information and getting it back to the state. Of course, this is still early data. We have seen some additional grace periods provided to members. So October data, as we get that membership information, is going to be a really telling month, because that will basically include 2 cohorts of members, both the September and October cohorts. Will all be going through that process for October, because the state provided an additional 30 days to the September cohort due to some system issues. So once we get that October data in, we'll have effectively 3 months worth of redetermination data at that point, and so we'll be able to provide quite a bit more detail on what kind of trends we're seeing in that, which we'll certainly bring to the October Managed Care Committee meeting. The next slide shows our operations metrics. All of these metrics are continuing to operate within our SLAs, so no areas of concern here. Next slide. This shows our inpatient admissions per 1,000. Red is the prior period, blue is current period actuals, and then the very light blue shading is projected forward. You can see we're continuing to see a downward trend overall in the admissions per 1,000. We do expect this may reverse as redetermination continues, as the acuity of the members that stay on Medicaid is likely to increase, so that's a trend we'll be monitoring over the next year. The next slide is our COVID vaccination rates. These have continued to stay relatively steady. We, continue to see new members coming onto the program. We continue to see a number of them get their initial vaccination series, but overall, on a percentage basis, those that have been vaccinated is staying relatively steady. We will be launching campaigns now that the new vaccine is out, and tying that in with a lot of our annual education around the flu vaccine as well as RSV. So more of that work is to come. The next slide shows our claims payments. You can see that we had some uptick here over the past 45 days, but we've driven that back down, so we're getting pretty close to the steady state of where we'd like that to remain. And then the next slide just shows that on a aging category basis, so 30, 60, 90 days. You can see most of that fluctuation has been in that 30 to 60 day category. But claims over 60 days and over 90 days has continued to be very minimal. And with that, I'm happy to answer any questions.
I'm curious, your 90% is absolutely outstanding. What would you attribute that to?
Well, first, a huge thank you to our team that's done an incredible amount of work, and that's really across the entire team, from outreach to call center to care coordination staff. It's really like every individual, every touch point we have with the member is a part of that. And then I think we've done a lot of thoughtful approaches in terms of how we sequence communication, how we try to engage and make sure that individuals get that information, the time they get that information in the process. And then, obviously there's still opportunities, and we do have a window still for that 10% that didn't respond that we can continue to try to outreach and connect with them. So we'll be trying some different approaches over the next couple months because we have 90 days from the point that they lose coverage to try to get them reinstated back.
Great job.
Very well done.
Hey, it's a great job.
Yeah, I have an observation. With the exception of fee for service, it seems that everybody is between 85 and 90%. So we may lose fewer people if that projection is correct. If this data is indicative of what's going to happen moving forward, we'll probably lose fewer people than people expected.
Yes, I think at this point we're exceeding kind of what our expectations were. Again, certainly it's initial data, so I think as we get the October data in, we'll have a better sense of how we're trending. But right now, the results look very positive.
And we could call that encouraging.
Yes, encouraging.
Indeed.
We'll
I
take
would
it.
also like to just echo congratulations to the work of the team. The plan that was presented to us months ago was very comprehensive in terms of its approach. And these numbers are at the low end, if you will, the expectation of leakage early on at this point. And with further opportunity to capture or to bring more people in, this is extremely encouraging from what I've seen over many, many years when we've gone through these types of redetermination cycles. So again, I'd like to put a record, thank you and your team for the focus on this, and looks very encouraging for what the final results will be.
Thank you.
Thank you. Next, Director Bott will now review the Quality and Patient Safety Committee meeting minutes. Director Bott.
Thank you, Mr. Chairman. Good morning. The Quality and Patient Safety Committee met on Thursday, September 14th at 10:30 a.m. We're not planning to have any review of the metrics and presentations for the meeting, but if there are questions, our wonderful staff will be present, ready to address. Next meeting of the committee is October 12th at 10:30 a.m. The committee received the following reports that are included in the minutes. The HRO dashboard, which included information on the following subjects and metrics from the HRO work groups, which I think have been doing a wonderful job moving through that. Patient experience, clinical documentation, clinical outcomes, readmissions, throughput, HEDIS. Those were all the metrics we reviewed, and an update on strategic initiatives. We also received a regulatory accreditation update. We received an update from the HRO work group on clinical documentation, received an EMS and MEC reports. We received the Stroger Hospital and Providence Hospital Quality Committee summaries for informational purposes. On action items in that meeting, the committee approved the following action items, which are included in the minutes. 5 Stroger Hospital Department Chair reappointments and 14 Division Chair reappointments were approved. Approved Stroger and Providence Hospital medical staff appointments, and approved the proposed Providence Hospital 2023 Quality and Patient Safety Plan. We also are going to review in the next committee meeting some of the data from the mortality numbers that were presented by Dr. Mikaitis. The committee did receive information in closed session, but those reports are not expected to be re-reviewed. So if there are no other questions on the minutes, they're being presented for the board's consideration at this time. Back to you. Any questions? All right. All in favor of approving the minutes?
I'll take care of that.
Got a motion?
No, I'll take care of it. I think you made the motion.
All right.
I'll take care of it. We'll take care of it.
Mr. Chairman, sorry. Yeah.
No worries. Before we move on, I'd like to acknowledge the presence of Director Ryder. Now I'll make the motion. Okay. It's a long one. That was a long one.
Oh, right.
I'd like to entertain a motion to approve item 4D, the September 14th minutes of the Quality and Patient Safety Committee meeting, which include the approval of 5 Stroger Hospital Department Chair reappointments and 14 Division Chair reappointments, approval of the Stroger and Providence medical staff appointments, reappointments, changes, and approval of the Provident Hospital 2023 Quality and Patient Safety Plan now.
So moved. Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor? Aye. Aye. All opposed? Thank you. The ayes have it, the motion carries. Thank you, Director Bott.
Thank you, Mr. Chairman. I did not hear anything, so I didn't know if it was coming forward. Appreciate it.
We're all good. We're all good. Thank you, Director Ryder. Next, Director Ryder will now review the Finance Committee meeting minutes.
Thank you, Mr. Chairman. The Finance Committee met on Thursday, September 14th at 9 a.m. The next meeting of the committee will be held on Thursday, October 12th at 9 a.m. The committee considered the following action items, which are included in the minutes. Conditionally approved 23 contract and procurement items. Numbers 2, 4, 5, 6, 7, 9, 11, 12, 17, 18, 19, 21, and 22 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee whose fiscal impacts are greater than $1 million, which are highlighted for your information. The committee also received and filed grant award related items and transfers of funds. The committee received the following reports, which are also included in the minutes. The my MBE WBE report. One emergency purchase was presented. Report of the fiscal year 2023 financials and update on strategic initiatives, which was not reviewed at the meeting, but was sent in advance and is included in the minutes that we have today. And we also received the report from the Cook County Office of Contract Compliance. And with that, Mr. Chairman, if there are no questions, the minutes are being presented for the board's approval at this time. So moved.
Thank you.
Second.
Any questions before we have it? Thank you. Thank you. I'd like to entertain a motion to do this, to approve item 4E, the September 14th Finance Committee meeting minutes, which contain the following action items, because we have action items. Approval of the contracts and procurement items and receiving the following grant award related items and transfer of funds. Now.
So moved.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? Thank you.
Chairman, Mr. Chairman, can I
Yes.
offer a comment? Mr. Chairman, can you please record me, Dr. Bott, as voting present on request number 7 and 23 under the contracts and procurement items, and voting present on the transfer of funds relating to county care contained within item 4E, the September 14th Finance Committee meeting minutes.
We acknowledge your present vote. Thank you.
Chair Taylor, can you
Thank you.
record me also as voting present on request number 23 under the contract and procurement item, voting present on the transfer of funds relating to county care contained within item 4, September 14th Finance meeting?
Correct. We acknowledge the present vote. Thank you. We do not have any contracts being presented directly to the board for consideration, so we can move on to the next item. Is Ms. Kimberly Kraft here? Yes, next, Kimberly Kraft will review the employment plan officer semi-annual report. Ms. Kraft.
Good morning, everyone.
Good morning.
Okay, so what I'll start with, just for the broader audience, is just kind of a quick review on what is the employment plan and what is it that the employment plan office does. So the employment plan is a manual or a rule book that governs how we go about hiring here at Cook County Health. We also, through our supplemental policies, that they govern how we process non-hiring employment actions. What do we do through these? The employment plan prohibits discrimination. It contains proactive processes and procedures that prevent the opportunity for discrimination. They contain transparent processes and procedures and require collective bargaining agreements to be honored. As you know, we're heavily unionized, so The rules that are in the employment plan and supplemental policies apply throughout system-wide. However, to the extent that we ever have a provision in an applicable collective bargaining agreement that conflicts, then we have to honor that. So sometimes what happens is we'll have what I call a custom blend in our employment actions of the employment plan or the applicable supplemental policy, and then, you know, what the CBA requires. What does my office do? So we are a team right now of 4, I'm not sure if the whole staff is here. We do have Drew over there, Andrew Jester, our program manager. We're a team of Cook County Health employees who oversee and support compliance with the employment plan and the supplemental policies. So how do we do that? So we do prepare training materials so everyone knows what the plan is and what it requires. We provide that training along with HR. We observe and audit employment actions to assess compliance. That could take the form of observing in person, you know, maybe some interviews or selection meetings, or it could be review of documents after the fact. We always work on developing strategies and procedures to help support compliance and achieve compliance. We do have an investigative function where we are brought complaints of non-compliance. We do look into those, and reports result at the end of that. We do report all allegations of a political contact and or unlawful political discrimination to the Office of the Independent Inspector General. We do maintain the direct appointment list, and we issue semi-annual EPO reports. That's part of, you know, the transparency function. And so that's really why we're here today. So I recently issued the semi-annual report covering January 1st through June 30th. That report will go on the website, and today is a summary of that. Ready for the next slide. Okay, so as you all know, I know Ms. Amos has spoken to this at great length in the past, and we've all observed it ourselves through the pandemic and the Great Resignation. We faced challenges here and nationwide with hiring and recruitment and retaining staff. And so we really needed to look at how to streamline our hiring processes. And so the employment plan is a part of that. It's one of many factors that play into the time to fill a position, but early on, right away, as you know, my office and HR started working collaboratively on some temporary quick modifications to the employment plan that would keep things moving more quickly. The revised hiring process still in play, and the revised hiring fair process, which did result in the day of hiring fair offers. So those were both done at the same time. You know, HR and their optimization team worked on streamlining some other things. So there's been a lot of efforts from the very beginning to really speed up our hiring process. But the last time I presented to you, I mentioned that our CEO, Mr. Rocha, had asked for a multidisciplinary team to assemble and really think through how we can make permanent amendments to the employment plan to even further streamline our hiring. We do have an amendment process, so that is allowed. And so very happy to report, I know Valerie Amos has already mentioned the accelerated hiring process that was piloted. So that did result. It was rolled out shortly into the next reporting period, but I'm covering it today because it was developed during the reporting period. So it is a permanent amendment to the employment plan. It does really significantly reduce the time to fill. What was really great about it too is we did not have to offer or develop any special training for it. It incorporated pieces of what we had already been using, so it could be implemented immediately. And it's been piloted with nursing with good results. So really happy and pleased with that, and really looking forward to returning to the table and continuing to work on additional amendments to the employment plan.
Yeah, I have a question.
Sure.
The amendment you're referring to is the process?
Right, the revised, the accelerated hiring process that was piloted for nursing, yes. So it is a permanent amendment to the plan, and so it was piloted with nursing with success. So really looking forward to, you know, continuing to look at how we can further modify the plan and continue reducing the time to fill. Beyond that, just wanted to announce, you know, my office faced the same types of challenges seen nationwide and here at Cook County Health. with staffing. For a period of time, we were as low as 2. Now we are up to 4, which is great. At the beginning of this reporting period, we did lose our one and only analyst, employment compliance analyst. A very critical role. That's the person responsible for day-to-day monitoring, auditing, also involved in our investigative function. So it was really important to fill that quickly. Moved on that, and we did fill the position. Bianca Willis started a month ago, August 28th, so we're really happy to have her, and she's already proven to be a valuable addition to our team. So very pleased to announce that. Next slide. Okay, so I did mention we do have an investigative component of the office. The last time I presented to you, I did mention that we had a significant number of pending complaints that we were investigating with the Great Resignation and prioritizing all of these changes, short staffing. You know, we had over 100 pending investigations the last time I spoke with you. You did ask for a couple things. You asked that we prioritize closing investigations, concluding them, as well as you asked for a list of our pending investigations and the date that they were open. So that list has been incorporated into the report that was issued, and that will be on the website and available. But I'm really happy to report that in the applicable time period, we were able to close 51 of those investigations. And I have to give credit where credit is due, especially in light of the fact that we did not have an employment compliance analyst at that time. I have to give credit to Andrew Jester, the program manager, who worked really hard to process those and to get those closed. So right now, in that same time period, we did get 21 new investigations. So as of September 20th, we are at 78. We are continuing to work through those. We do have an employment compliance analyst now, so that will be a huge help. And we also, as we look at the employment plan and potential amendments, we will be looking at if there's any way to further optimize that part of the plan to build in some additional streamlining there if it's possible. Next slide. Okay, so here is the point where I'm going to go through the employment plan office's observations through monitoring over the applicable period. I'll go through very quickly, starting with the appointed positions. We have different types of positions that are appointed. We've got our direct appointments. Those are appointed by the CEO, medical staff appointments, and executive assistants. Happy to say that everyone who was appointed was qualified for the position. So with medical staff appointments and executive assistants, we didn't see anything at all, to point out or of concern. The one thing with the direct appointments is there were 3 instances in which the employee was onboarded prior to the date that the Office of the Independent Inspector General's approval was provided. Next slide. Okay, so now moving on to our non-appointed positions. The same as mentioned, we've had a lot of hiring fairs that continued in the reporting period. In that 6-month period, there were 25 of them. And so in the past, we've talked through, this is a revised temporary hiring process that has been kind of modified over time to kind of optimize it and kind of iron out some bumps along the way. And so at this point, the planning process with the advance notice and planning period being reduced through some amendments, there was a need to really strengthen the advanced planning process, at which point we give approval for a fair, just making sure that there's compliant planning on the front end so that we don't run into problems on the back end. And so that process, I would say, is very solid at this point. Very happy with the way that's going. In the past, we have mentioned had some observations about how the documentation is organized and maintained. There are improvements in progress there. We have, continued to meet with the team that oversees the hiring fairs, and it's a very collaborative process, and we're definitely on the right track with getting that in line. And then, we've noted in past reports, completion and the use of consolidated ranked lists. So the list of people, once the the vacancies for that day have been exhausted. Those go on a consolidated rank list for use later. In the past, we did have observations about completion of that form and use of the list. Again, we've talked about that. Again, continue to go over that, and improvements are in progress. So really happy with the direction things are going there. Moving on to the revised hiring process. That's our big temporary process that governs our general hiring and actively recruited, our two main hiring processes. We looked at a sample of decision to hire packets for 1 week of the reporting period to kind of see what was going on with those. We did note some interview question non-compliance there. We talked about this in the past. There was, in this particular hiring process, a requirement that the questions be tailored specific to the minimum qualifications. Talked about that with HR. You know, the questions were not specific enough in our opinion. However, after talking with HR, talking with the Office of the Independent Inspector General, we did agree that there were sufficient safeguards in place throughout the process, through screening on the front end, the validation process, and the final screening by HR on the back end, that requirement could be taken out. So that amendment was made. We did notice some missing signatures on interview evaluation forms. We did share that with Human Resources, and that was corrected. And we did notice that we did not seem to be getting notice in all cases when the validation on the front end, the screening and development of the interview list had been completed. HR was able to identify the cause of that and correct it. So no concern there. I think that's all, and unless anyone has any questions, we can move on to the next slide. Now moving on to the supplemental policies. As I mentioned, you know, with the plan, we have the supplemental policies, so same governing principles apply. These cover our non-hiring employment actions. So interim assignments, you know, this has been something that I've brought up in past reports. So there were 50 interim assignments in pay approved in this applicable period. The majority of those were extensions of pre-existing assignments. We did notice some compatibility issues with the two policies, the interim assignment and the interim pay policy. This is something that, you know, HR has agreed with us on. This has been on the radar for a while, and so it continues to be on the radar. This is something that will be corrected. And so in the meantime, we made some recommendations for how compliance can improve pending those policy updates. Moving on to discipline. So discipline is done at the department level, doesn't really involve HR approval until you get to the point of suspensions and termination. But what happens is departments will send their completed paperwork to a discipline account, you know, and we have access to look at that. So there is a team within HR that will look at those. They, you know, look at them for compliance, they track them and do all that sort of thing. We independently do a review of some of them just to kind of look from our perspective, is there, you know, are the departments complying? And so in this particular reporting period, we looked at 75. Time and attendance continued to be the top infraction that was cited in our disciplinary, in the disciplinary actions. Types of noncompliance have been consistent with what we've seen in past reports. There are two buckets that I kind of break them up into two buckets. Some things are, you know, small administrative errors, easily corrected. Others might have a more significant impact either on, you know, the validity of the process itself or the ability of HR to maintain the permanent record in its file for use in later actions or for reference later. So what we do is we track our findings, we share those with the HR business partners, and then they have that information to follow up as appropriate and as necessary. Moving on to the next slide. More supplemental policies. So there were some layoffs in this applicable period, 40 plus. We did receive the majority of the paperwork as we were preparing to issue this report. So that review is pending and we'll include our review and analysis in the next semi-annual report. Training opportunities and overtime. So for all of our employment actions and, most of our other supplemental policies, we've got a lot of forms that we use, and every time a decision maker is going to make a decision in a process, they sign that form. That includes an NPCC within it, no political consideration certification. The training opportunities and overtime policies are not really conducive to that. So how NPCCs are handled is they get sent out to our department heads twice a year electronically, and they're submitted that way. And so we sent out NPCCs. They were due the most recent time they were due was June 15th in the applicable reporting period. We sent them out to 211 department heads, and we're down to just 12 that we're still waiting for responses from. So, and we'll continue to follow up until we get full compliance there.
Excuse me, I'm sorry. So they were due on
June 15th? Yeah.
And we are at, what's the date? September 29th. Thank you. So what's the procedure to get them to certify?
So at least at this point, I'd probably just do one more reminder,
Okay.
and then past practice is then to send an official letter for their personnel file.
Thank you.
And then, let's see, getting near the end, we're getting to reclassifications. We did get one determination produced to us for the reporting period, no concerns. I did mention here on the slide that there were some past known requests that we were uncertain about. I did learn subsequently that some of them kind of just, I don't know if they were officially withdrawn, but the department decided to go in a different direction. And then there are some recommended process improvements we made in the prior report, and those are pending, so going in the right direction. Okay, I think this is the last of our observations here. For third-party providers, these are contractors that provide recruitment functions here. So there's a policy that governs that, how the requests are made, how they are, what their contracts have to say, the training that they have to have, all those sorts of things. And so I did note for this applicable reporting period that HR is really tracking things very well, so that's a really positive development. There were 9 contracted recruiters. We were not certain of whether they had completed all required trainings or not, so that was just kind of something that's still pending, and we'll follow up on that and report on that the next time. This is another one where we were kind of working on process flow, document maintenance, those sorts of things, and so those are still pending, but I'm confident that that's gonna, we'll get through that. And then finally, grade 24 salaries. There are policies that cover how our grade 24 positions, the initial salary and how they are adjusted. We did get 9 packets for increases, again, as we were finalizing the report. So I don't have our analysis in the report that's being put up on the website, but that will be included in the next semi-annual report. And then over the course of the reporting period, there were 3 times where we had to ask questions about salary determinations for new hires, and they were just minor administrative errors that were corrected. Okay, next slide. So what's coming in the future? So for purposes of transparency, which is huge, right? We want to make sure that we get formal documentation of both the temporary and permanent amendments to the employment plan dating back to last year. So we need them to be formalized, put in the plan that we can put on the website to provide that level of transparency. Still looking for website updates, the job descriptions. I believe that's still a work in progress. They are required to be on the website, so that will help happen. Ultimately, we did talk to HR about some adjustments to the quarterly report that goes up on the website, some additional data to be added there. I talked to last time about the employment plan office page. We didn't have one. I thought it was important to kind of make a user-friendly one-stop shop to access all things, the employment plan, the supplemental policies, and everything.
I got to stop.
Required by the plan. that is almost done. Have been working very closely with Valerie Amos and her team and Alex Normington and her team, and it's very close to going live. For plan and policy updates, again, really looking forward to continued modernization of the plan, and then the interim assignment and interim pay policy still, continue to really look forward to that being amended. And as far as plan training, we do have with HR lots of plans for training updates in the future, both for our interviewer training. Obviously, we're in a state of the plan is being amended, so once that's done, we'll really be updating all of that. Our annual trainings and refresher trainings as well will continue. Last slide. And then we just some joint HR and employment plan office initiatives I wanted to mention. We are preparing to roll out, I don't know, for lack of a better, fancier terminology for it, discipline resources, which is kind of in line with what HR created for, for hiring, the Hiring Central. This is meant to be a one-stop shop for our leaders to be able to access a page with links to everything that they need in order to implement discipline. The policies, the templates, supplemental, training materials, resource guides, all of those sorts of things, contacts for those people who exist in the system to help them out with questions that will all be put in an accessible location to make everyone's life a little bit easier. Continuing to work on just information document sharing between my office and human resources. We look at pretty much everything, and just, in talking about optimization, we want to be able to see as much as we can, as efficiently as we can, so that we can cover as much ground as possible with the staff that we have. So continuing to work towards that. And then just finally, automation of discipline. This has, again, been on the radar for HR and for my office for a long time. Discipline is, I believe, really conducive to automation, and I believe it will really improve compliance. And so really looking for, I think we're getting to the point where we can visit that, and so I'm really looking forward to being able to engage and participate in the process of automating discipline. And that is all I have for today. Any questions?
Any questions, directors? Thank you very much, Kimberly.
Okay.
Appreciate it. The next item is a report from the CEO, Mr. Rocha.
Wonderful. So we have some good recognitions that we want to go ahead and start with. So we want to start to the next slide. First, we wanted to update the Board of Directors that Cook County Health's John Strozier Hospital has been named as the #1 most racially inclusive hospital in the state of Illinois and second most racially inclusive hospital in the nation by the Loan Institute Hospital Index. The 2023 Loan Institute Hospital Index racial inclusivity metrics measure how well more than 3,000 hospitals served patients of color using Medicare data from 2021. We want to thank the entire Strozier team for their hard work in ensuring that our patients have access to high quality care when they need it most. So we're very excited about our care team, about their quality outcomes, and their dedication to ensuring that everyone, regardless of any barriers, financial or otherwise, receive the care that they need, and that we offer the world's best services to all patients in need. So we're very excited about that announcement.
Well done.
Next, also continuing some very, very positive news. The National Commission on Correctional Healthcare Accreditation has given full accreditation of Center of Excellence to CIRMAC Health Services. CIRMAC Health Services earned accreditation by the National Commission on Correctional Health Care. That's the NCCHC. CIRMAC demonstrated compliance with NCCHC's nationally recognized standards of care and outstanding commitment to patients served in the Cook County Jail and the Juvenile Detention Center. Congratulations to the CIRMAC team on this amazing accomplishment. Also, we wanted to share that Hospitals and Health Systems to Know, Becker's Magazine, has recognized Bina Peters. So congratulations to Bina Peters, Cook County Health's Chief Nursing Executive, for getting recognized by Becker's Healthcare on CNO's To Know list. This included leaders who bring a unique blend of clinical and leadership experience to their roles in healthcare. So congratulations to Dr. Peters.
Well done.
And also with us today, Lisa Brown. Dr. Brown was recognized at Purdue University. She has been named as the 2023 Distinguished Alumnus Award. The College of Health and Human Services is proud to recognize their alumni for their outstanding career development, achievements in leadership, as well as significant contributions that they have made to improving the lives of individuals, families, and communities. The award will be presented as a special dinner on October 15th. Please join me in congratulating Dr. Brown.
Where's Dr. Brown?
Dr. Brown, do you want to stand up, please?
I don't see Dr. Brown.
She was here.
Well,
All right. I'm not, we're not congratulating. Hopefully she's watching. Thank you, Dr. Brown. National Association of Healthcare Quality has recognized Dr. William Trick. Earlier this month, Dr. William Trick, co-director of the Center for Health Equity and Innovation, presented alongside representatives of the Joint Commission, the National Association for Healthcare Quality Conference. The session was called Putting Joint Commission Accreditation Requirements into Practice, Implementing Processes to Drive Change in Advanced Healthcare Equity. And in this presentation, along with the Joint Commission, Cook County Health was highlighted for CCH successful health equity initiatives and helping to bring care to all individuals in need as a center of excellence around the country. So congratulations to our quality team, our equity office, for being highlighted in the National Association of Healthcare Quality.
well done.
And next, wanted to share just an update on our strategic initiatives for our September report, what's accomplished and what's coming soon. So for accomplished, we wanted to celebrate, you heard a little bit about it in Valerie Amos' report to you, but we had the largest HR orientation class with 64 new external hires who joined us. So we're seeing an upward trend and we're seeing them join, and they were very excited to be part of the Cook County Health family. CCDPH completed naloxone training for the Department of Corrections. The new CareLink provider agreement includes 5 high-priority skilled nursing facility partners. This is a positive step forward for before we had to do individual case agreements. Our CareLink agreement and plan network covers those individuals who have no ability to pay. And to ensure that all patients have one standard of care, Cook County Health pays for their ability to fully recover, including if they need skilled nursing facilities or other services that are provided, to help us to make sure that that process is expedited. Working in combination with our planned services, CareLink now has 5 priority skilled nursing facility partners to ensure that that transfer of care happens seamlessly. And so it's another step forward in ensuring that one standard care access that Cook County Health is aiming for. Our central processing department had an upgrade and redesign at Provident. We successfully accelerated the hiring process for nurses. Over 100 nurses offers were accepted, as you heard earlier. Our PAR Excellence has rolled out for scale and bin process at several floors on the Strozier. This is a very positive innovation, and so if you have or have not seen it before, our storage rooms were a little antiquated. Now they are fully automated where they have utilized the bin process. And what that means is that all of our supplies across both Strozier and Provident will eventually be tied to an automatic network. When the supplies are empty, they're immediately ordered through a computer process and put onto the floor with the correct PAR levels. As they're going through supplies faster, it sends an alert for the PAR to automatically adjust. If they're slowing down, it sends an alert to automatically adjust. So it's both a cost savings and a safety feature, and something that our staff, when I came on board and did my rounds coming into this job, it was the one thing that all staff and all floors said, what can I do for you? And they're like, help us to have the supplies that we need. So we're very excited that this has happened, and do want to recognize our procurement team who's been helping to lead this process throughout the floors. And so it's a great step forward. Our rehab services are restarting at Provident and continuing with our initiative to bring more care services to our Provident campus. We are rolling out palm vein readers throughout the professional building. STROMAC achieved anti-CCH accreditation that we discussed, and then Strozier's recognition by the Loan Institute. Coming soon, SingStack and County Care will offer a women's health fair. The clinical decision unit will be used to initiate workup and treatment for patients waiting in the ED. And what that really does is it sometimes will get avoidable delays. If you've ever had to be in an emergency department, you can find that you can just wait. One of the advancements to make sure that our care plan started is that our medical teams immediately, our emergency medical team will hand off immediately to our medical teams, and they will start your plan of care immediately in the ED, even as you're being escorted to the room. And so this makes sure that you're seen timely and that you get your tests done faster and that you can minimize your time that you have to be at the hospital while optimizing your plan of care. The positive Department of Justice report will be issued. A positive Department of Justice report will be issued for behavioral health services at our juvenile detention facility. We are at the process of completing our long-term facility plan. We also will be moving forward with our Behavioral Health Summit, which will be planned for FY 2024. This will bring conveners from all over Cook County, the city of Chicago, and the state to discuss what is needed in all of our communities to address behavioral health in a large, comprehensive fashion. And so this has been awarded under our ARPA funding and will be a very large conference, and we'll have an accompanying report that would actually document everything that was discussed, the improvement pathways, and hope to create a behavioral health plan that has broad agreement and support from all the jurisdictions in the county to be able to move us forward. And so we're excited about this convening coming together. It will be utilizing something that's recommended by the CDC called a pro-seat, per-seat fashion that actually brings large groups together, and the public health departments have to use to start up new initiatives nationwide. And so we're excited about that process.
Excuse me. When and where?
Right now, it is being decided. We just released a contract for the individuals who have been selected to lead the conference as we needed help. It will largely be, I believe, in the spring of 2024, but we will get you an updated agenda coming forward.
Thank you.
Mm-hmm. Thank you. And part of this preparation will also be going out into work with community groups. And so they will also get feedback from the community, from patients and individuals who need behavioral health services to make sure that that is also incorporated into the report.
I'm
Mhm.
curious, will I'm not sure if they're called the disruptors,
Violence disruptors. The violence
yes,
disruptors.
will they be included?
If you have a recommendation of group, we are happy to include
I
them.
don't know anyone who's giving just what I should do, but I'm just thinking about because mental health is a real issue that's undiagnosed.
Absolutely.
And they're talking to the people.
We will definitely make sure that they're included. So the broad part is that they're going to first do analysis of who needs to be included, and then they're going to have the meeting with those groups. And so we'll make sure that that is something that is evaluated. And one of the focus especially is looking at undiagnosed. And why we're doing this initiative and started in behavioral health is that it's one of the conditions where we see the longest lead time between initial onset of symptoms and any treatment. And so in most events, you may be undiagnosed and it's silent, but in mental health, you actually have active symptoms. And it usually takes 12 years for an individual between they actually get in treatment. So from the first onset of symptoms to your treatment, the average report is about 12 years, and we would really like to minimize that. And so that element that you discussed, looking at how we can be able to address that, groups such as disruptors or others that can be helpful in understanding that will be part of the process. We'll make sure that we evaluate that.
Would it be helpful in identifying some of those potential violence disruptor groups
Absolutely.
and to listening, because we can provide some information on what maybe some groups to tailor to for those of us that work in outreach in the community, can give you some names of some of the groups that are right on the ground to be able to be included in this.
Please send it in. And it will actually, we also have a coordinating committee, and there'll be volunteers that will be asked to serve. So there'll be a whole wide community process. We just awarded the organizing committees. We needed some help and support to make sure that this gets done appropriately with the voice of the community. So as that gets forward, we'll also have them present to the board as well to bring some ideas. And we'll be sending that information to the board and to the entire community of how they can participate in this process.
And this will address, I think, Commissioner Deere's legislation about violence being a health problem.
Absolutely.
Exactly.
Yeah.
Exactly.
So it's fantastic.
Absolutely, it is fantastic.
So we're very excited. We'll be bringing more information to come and absolutely incorporating those elements. And it's a start of a great conversation going forward.
Do we know the timeline on that?
Again, I think they're looking to try to do it in the spring or fall, but I want to make sure that I'm accurately moving forward with their presentation. So what we can do is we can share their submission with the board on everyone that was the winning submission, and then we will also have them be able to come and present to the board as they're developing their plans.
Okay.
And we'll also be sending out any meeting notices, because they're gonna be having community meetings to be able to get information.
Okay, good.
Also wanted to recognize that we will be coming forward, the closed loop referral for behavioral health is being launched. That's a process that lets us to make sure that people actually got to the therapies that were recommended in the community. And so that way we can actually track that moving forward. And that will also be able, that is something that will be offered to community CBOs as well. Before, we could only send out the referral, but we wouldn't know that the patient actually received the services. Through a new software system that's being developed, we will actually be able to get that information and put it into the medical records so that our care managers and providers can see that they're actually getting the assistance that they need. Also, CCDPH will be distributing naloxone and naloxone kits, supplies, and training to community groups to help us address the opiate crisis that we have been seeing grip of the entire country. And then CERMAC is preparing for NCC-HCC mental health accreditation. Some of them got their correctional health for accreditation, and then there is a specialized accreditation for mental health services, and they will be pursuing that as well. Any questions? All right. With that, then also we have been bringing you updates from our service line. So I'd like Dr. Patel, and I don't know if Erica's with you today or just. Wonderful. So Dr. Patel will be presenting a cancer services line update to let you know what is coming forward from our cancer services programs across Cook County Health. Dr. Patel?
Good morning. Thanks. Good morning. Rajeet Patel. I've been the chair of otolaryngology head and neck surgery here for about 16 years and currently serve also in the role of interim director of the Cancer Center, which is what I'll present to you today. This is the work of a lot of people, obviously, including Erica Radicke, my director of operations, as well as the whole cancer team. Again, it's our first time really presenting to you in this forum, so I wanted to go over a little bit of history just for 2 minutes. The Cancer Center service line is a component of the Change Institute, an initiative by Mr. Rocha and Dr. Fegan, and now Craig Williams, one of our executive sponsors. And we have a mission, a vision, and values that are really in line with the whole institution. I think the mission is worth stating at least once out loud, and that's to provide the highest quality integrated care across the cancer care continuum for the community we serve. Again, our vision and values are aligned with the institution, and this is what guides us. Next slide. Cancer care is obviously complicated. This is the entire continuum of what we are trying to build, and this is a progressive work in progress. The things in the middle, in the treatment box, those are the obvious things. Radiation therapy, surgery, chemotherapy, that's what many of us think of as cancer care. But as you can see, it's far more than that. It begins all the way at the beginning with cancer prevention, cancer screening, all the way through diagnosis, treatment, and then on to survivorship, and also end-of-life palliative care. So it's worth underscoring that these aren't bells and whistles, these aren't niceties. These are expectations of a comprehensive cancer program. These are all certainly things that competitor organizations are doing, and these are all things that we really need to be doing. Again, that being said, it can be done in a fiscally responsible way, and we obviously are paying attention to that as well. Next slide. We have a board of leadership for the Cancer Center. It's roughly 8 clinicians, as well as me and Erica Radicke. 2 years ago, we developed this 5-year plan, and this is something that's been reviewed by our CMO, our CEO, our Chief of Strategy. And we've been making steady progress through this over the last 2 years that we've really been up and running. And I don't want to go through all the details of this right now. We'll get into accomplishments in just a moment. But we do have a 5-year plan that is guiding our actions, and we're actually making very steady progress through. So far, I'm proud to say none of the initiatives on this 5-year plan have been abandoned. They've all been either accomplished or potentially postponed, but still, in our target sites. Next slide. So accomplishments, and this brings us up to speed on what we've been doing over the last 6 to 12 months. Probably the greatest accomplishment is our reaccreditation survey by the Commission on Cancer. We're reviewed every 3 years, and this is the 5th cycle that I've been guiding our institution through that process. We had by far our best performance with a nearly flawless review, only one minor regulatory deficiency. And this is no coincidence in time. This is directly related to the investments made in the program in the last 3 years, I think specifically by Mr. Rocha, Dr. Fegan, and the administrative team, and you as the board of directors, obviously. So really a spectacular survey that I'm very proud to say is the state of art of our cancer center. Moving on, we've developed a cancer survivorship program. Again, this is really a necessary service that we provide to our patients. It's existed in its infancy in various ways. It's now being formalized with additional staff, and we're ready to unroll that over the year 2024. Something which the Board of Directors has probably heard of is the development of the stereotactic radiosurgery program. This is, again, a necessary service that we must provide our patients. The Board of Directors recently approved the purchase of 2 linear accelerators. This will allow us to provide this very necessary service, and as these machines are installed in 2024, it really assures the success of our radiation program for the next decade. Next, at a nationwide level, the operative standards are being unrolled. The Commission on Cancer would like us to standardize how surgery is both performed and reported. A lot of work has gone into this with Dr. Lazaro as well as our information technology colleagues to build tools in the electronic medical record to do just this. So again, we're compliant with the standard, and this has been a big initiative over the last year, and it's actually up and running. Next, also probably no news to you, we are developing a robotic surgery program. So historically, we've been one of the largest hospitals that doesn't have a robotic platform. That's not exactly something for us to be proud of, but we are proud that we are correcting this. So the robotic surgery program and purchase has been approved. A lot of work has been done by my surgical colleagues, Dr. Keene, Dr. Chowdhury, over this year to get this launched. So I think we're within 3 months of going live with robotic surgery. And the vast majority of that work will be cancer surgery, and that's why the Cancer Center is, of course, tightly aligned with the surgery department in launching this initiative. The next bullet is a single bullet, but it comprises a lot of effort. We have finalized inpatient, outpatient data dashboards, so we're able to track volumes, productivity measures, charges, payments, payer mix, patient-level financials by diagnosis, length of stay, all the things that you would want a fiscally responsible cancer center to be doing. Again, I think I can say with confidence, since I've been here long enough, to say this is not something that we've generally done very well with historically as clinicians, clinician leaders. But I think we now have the tools in place to really have our eye on all the right things as we build programs like this. Lastly, we've implemented a triage nurse workflow. This is really going to improve our ability to intake new referrals to the Cancer Center. These will both be referrals from out of the Cook County Health Network, as well as within our network of community sites and other departments. So again, we want to actively facilitate patients' journeys to our Cancer Center, and we're proud to say we've implemented this triage nurse workflow. Next slide, question.
Yeah, Dr. Taylor, just back on the robotic surgery program.
Yes.
Just a question, does this cover a full range of different cancer types, or is it specialized in one area, like prostate, the da Vinci procedures, things like that, or is it across the board? Sure, it'll be quite across the board and comprehensive. So the sort of the pioneer fields are urology with prostate surgery and OB-GYN with hysterectomies. But now robotic surgery, especially for cancer, is being done also for colorectal, head and neck, thoracic, and even some aspects of general surgery now. So there will be roughly 6 divisions in the surgery department that will be actively involved with robotics at the outset. Thank you. Yes. Next slide.
Yes, this question.
It's going, I'm sorry, maybe I should wait. It's the cancer care continuum. I have a question about that.
Sure.
The first segment that you have, prevention and risk. My question is, does your organization impact the number of Black women that have breast cancer, since that is something that's way beyond what it should be? And I'm not sure how we as Cook County Health really impact that, meaning that we're getting people in, giving them the right type of scan so that they're not getting something that placates but doesn't necessarily evaluate in the most appropriate way.
Yeah, it's an excellent point that the best way to treat cancer is to either prevent it or to catch it at an early stage. So we have a lot of effort that's being put into cancer screening, specifically for breast, specifically for our minority population. So again, this is something we've historically devoted a lot of effort to, but there's much more that we can be doing. We know that stage by stage, we're still seeing increased stage of cancer at Cook County Health compared to, statewide metrics. And that means we need to be doing better with screening, exactly what you're referring to. So we are doing some of that. We just need to be doing more of that.
Okay, thank you.
Yeah, picking up on that, I see in that slide that you talk about prevention and risk reduction. To what degree is the Cook County Department of Public Health involved in this? Because their focus is primary prevention. And I'm sure they have some programs that really are in line with what you attempt to do.
So we're trying to build it from the beginning at Cook County Health, and we haven't yet really partnered specifically with other groups. But areas like smoking cessation, HPV vaccination, those are a couple examples of some of our cancer prevention programs. And I think as we bring more staff on board in those areas, we want to be able to partner more with our other colleagues.
And we can, well, we're in the process of integrating their work together. When our work with Dr. Hasbrook, it really has been creating a very specialized campaign for making sure that people get tested, that they come out, that they get prevention, that they do their annual screenings. There's a lot of fear, especially in either getting prostate screenings and testing, getting your PSI, coming in for your breast screening, and making sure that you're even doing things like getting your vaccines that can be able to prevent certain types of cancer later on in life, HIV, other types of illnesses. And so we do have an education campaign. We've been working with Dr. Hasbrook and some media campaigns to help get that out there in the community. And then at the same time, we will be making, and you'll be seeing coming soon, especially in FY24, some modernization of things for like our mammography machines and low dose testing that will allow for greater screening, and even some higher end that will be probably coming later on in FY25, which is advanced CT services that have proven to diagnose cancers even faster with some advanced modalities. So those will be coming forward. But from start to finish, we will be working with the Public Health Department, and one of the biggest things that we can do in working with Dr. Hasbrook is to educate and encourage to come out and to participate in screenings, to know the facts, to be able to get your vaccines that can help prevent conditions, and then also to make sure that we are taking other steps in lifestyle choices that can help reduce those.
Yep, but my question is, are we currently working in collaboration with the health department, public health department, or that's the intention moving forward? That's what I'm not clear about.
So I would say right now, as a health system, we're working in collaboration, especially in maternity and other fields. We are about to align oncology with that on the education.
Thanks, Mr. Rocha. Let's move forward in the slides. Thank you there. This is a little bit of granular data that I want to share without hopefully getting too deep into the weeds. But a few accomplishments, again, as we're tracking our data through our program, I wanted to share a few key points. Overall volume, we're up 4%, and this is due largely to operational efficiencies, reminder calls, active involvement with patient navigation, which involves some new hires, which has been very productive for us, transportation support, and social work support. Press Ganey, again, this is the company that works with patients to do patient surveys. We've seen quite a large increase in responses. So we take this to mean that patients are being more engaged with the program and are actually more happy to report feedback. So number one, responses are up by 24%, which is a very sizable increase. More importantly, what are the results of those surveys? The next bullet demonstrates that our Press Ganey scores are actually surpassing our goals, which are set by our patient satisfaction department. So as you might guess, even a movement of 2% is really substantial. 3.6 over a several month period is really far more than we expect, but we're quite pleased with. We're also partnering with other aspects of hospital operations. So there's a lot of work being done on the readmissions issue. Readmissions, as you might guess, are not ideal. They are necessary at a low rate, but currently the oncology group is a little bit of an outlier compared to similar type hospitals. So we want to work aggressively to install support and strategies to prevent readmissions. So we're working closely with the hospital group on that. And then also in the Department of General Internal Medicine, that's where we're working pretty aggressively to improve cancer screening and cancer prevention. And again, this was getting at the director's earlier question about those programs. They exist, they do need to be augmented, and things like our low-dose lung cancer screening program and mammography, those are the high-volume, high-target areas to start doing better. Next, a few operational issues on the second floor of this building. That is pretty much our geographic cancer center on two of this building. We have the infusion center where chemotherapy is delivered, as well as the outpatient oncology and surgical oncology clinics. And so that area specifically is the focus of, sorry, could you go back one slide? I think we advanced ahead of, there we go. There we've, bullet number 5, the improvements to patient registration, depart optimization, no-show rate reduction. We've installed many processes there to just simply improve operational efficiency, focusing on prior authorization as well. Lastly, we've relaunched our behavioral health program, again, a very necessary component to the cancer continuum, where we have to pay attention to, you know, the psychosocial issues that are impacting our patient population. Next slide. Thank you. So areas to focus on for the next 6 months. Again, we want to finalize the purchase and begin construction of the 2 linear accelerators. This will probably be one of the largest construction projects for the Cancer Center over the next 2 years. We hope to have that up and running in roughly 1 year's time. Again, we're going to keep working on the 30-day readmission rate through our institutional partnerships. We will work continuously to validate and refine our data with our data dashboards. Interestingly, on the second floor, we're also going to implement the point-of-care lab. This is going to expand lab services to the actual location of the patients and really improving not only their throughput, but also their patient experience. You know, the idea that a patient has to wait for blood labs to move across the institution to get a test result, and for that test result to make it back, we can really improve the ability of us to do that in a timely fashion, and patient satisfaction really should be improved. We will actually launch our survivorship program that we've crafted and implemented once we have a few new hires through HR. Next, we're integrating our electronic medical record with genetic services. So genetics is really a program that we built up in the last 2 years, critical to cancer care as well as certain pediatric and neonatal care. We've got 3 wonderful practitioners leading that effort, and we will be streamlining their processes that once they're integrated in Cerner with the medical record, we can really greatly enhance our ability to do genetic testing for all of our patients. And that, again, is another critical element to prevention of cancer. If we can screen our patient population correctly and thoroughly for certain diseases, we really can either catch things early or prevent entirely. The next issue, we have a clinical trials grant that offers clinical trials to our cancer population here. It's up for renewal every 5 years. We're coming up on our renewal cycle, and so we'll be working closely with Mr. Rocha and the new research infrastructure that's being developed at CCH for the next iteration of that grant cycle. And lastly, again, focus on the continued improvement of the patient experience. Next slide. That may be all I have. I think that summarizes the state of the cancer program, where we've been, where we are, hopefully where we're going. And again, I thank the directors for the opportunity to present that to you.
Yeah, I have another question.
Sure.
This is part of your 5-year plan, and I'm assuming many of the things you're talking about that are occurring in 2023 were things were accomplished between 2021 and 2022. Because I do see that robotic surgery was listed in the bullet points for 2022. So are there things in 2021 or 2022 that you were not able to do that you're going to roll over?
Yes, so 2021, I'm proud to say, is complete. 2022, half of those are complete or works in progress for 2023. Probably only a few elements in 2023 are accomplished at this moment, but they're essentially rolling into 2024. So there's a little bit of postponement that's going on, but at least, again, I'm pleased to say there's nothing that we felt was completely not feasible or had to be abandoned altogether.
Thank you.
I'm curious, are you doing anything to determine what the drivers are to create the free radical that starts the process? So if you're doing the genetic testing to see if one is predetermined, but that's great to know that they're predetermined, but then it becomes the next question, right? To say, what are those drivers that create it, and then try and, I'm not sure this goes beyond it, but to see where can we get assistance or help them become educated how to prevent those drivers from actually enacting.
Yeah, no, I think you're bringing up a great point. We need probably 5 different components of that continuum to coalesce together to really help prevent cancer. So genetic testing, of course, patient education for risk factors, cancer prevention through vaccination, smoking cessation, all of the known, risk factors that are mutable that we can actually change. So the genetic ones we can't change, but we can be aware of, and there'll be certain screenings that would then follow somebody who tested positive for genetic predisposition. There are a whole range of cancers that really have known risk factors that the more we educate, we can help people avoid, and then again, better screening doesn't really get at the 2 other issues, but simply helps to just detect cancer at an early time that we can actually intervene. So I think I would summarize it to say we need all of those to work in concert across the health system to be effective at our goal of reducing cancer.
Thank you for your presentation, and I wonder if you could discuss as part of the cancer care continuum, how you're incorporating the utilization of family into this process across the continuum. We know that particularly for underserved groups, research shows that a targeted family development, incorporation and involvement actually increases the likelihood that individuals present for prevention, that they follow up if something has been detected, like genetic screening. And so family, even with marketing tools that utilize, nagging them to go and get prostate checks, et cetera, has actually been successful in developing this across the system, as well as to provide caregiver support once patients are diagnosed. Can you speak to some of the things that you're utilizing across this continuum to make sure that families, particularly for our cultural care needs, are involved and actually even maybe a check mark in the process across these?
Sure. No, it's a great point that, like you said, family is a lot of the driver to better health as well as to accessing the healthcare system. So specifically, it's our partnerships with the Department of General Internal Medicine, partnering our cancer providers with the primary care providers that are at the community locations. A lot of that partnership is directed at how do we get patients in for their respective screenings, how do we educate them about the necessity of this. While they're here, how do we remind them about their family members? So we are paying attention to exactly what you're talking about. We're also, again, a lot of our ancillary staff in the PB second floor down onto both our social workers down there, our behavioral health workers, and we have a new clinical psychologist who's also come aboard. All of them are being involved in exactly what you're talking about, that how do we take a patient and make it so that their whole family is sort of invested and involved in cancer care, cancer prevention, and so forth. We do have a community outreach plan that's going to be coming up in the next 1 or 2 years. It still requires a little bit more staff to be brought on board. I think so to do what you're saying better will take a little bit more work. But somewhere in the 5-year plan, you will see modernization of the mammography and breast cancer area. And that specific bullet point is directed exactly at what you're referring to, that often it's the women, the mothers, who sort of drive, what a family might do for healthcare. And so when take something like mammography, which is so fundamental, if we don't have a space that is welcoming and appropriate and competitive with other healthcare organizations, we're sort of losing the battle of your very point. So that's just one example of a starting point of that, but that's something that we are focused on.
I think listing that as part of what you're doing will also help you to center it. and then recognize along this 5-year plan, actually a component of how, as you're bringing on board psychological services and behavioral health, that you're developing a specific plan of family engagement across those continuums, and that way there's actually a parameter and benchmark as part of your reporting that we can ask questions to, particularly since they're part of the preventive services and other questions that have been brought along with this as well.
Great, I appreciate that. I'll take it back to the group for sure.
Thank you.
And what I'll ask, Director Earl, update, very early on in our planning, one of the things that we will be doing with our ambulatory care team is creating a population health approach that will look at creating pathways for certain types of high-risk medical groups. Oncology would be one of them. So if anyone were to screen positive or be at risk, we would work with ambulatory care to integrate our care management, work with county care, and then engage our care managers and social workers to create specialized care plans for support of the patient. That's something new that is early in the development process, so we'll bring back to you, that is being led by Dr. Irons, our head of our ambulatory care program, along with Dr. Trek and also Dan Krill, and then we will be working with our county care team to create those alignment and pathways, but it's something early on in the development, but very central to what we're looking to do to make sure that you have that holistic support of the patient.
Yeah, wraparound has been such an incredible utilization through this. So the wraparound, including that, would be nice to be able to delineate it. Plus, that's a marketing highlight that you can utilize too, that you're utilizing that activity as a means of increasing not only care, but decreasing potential risks and epidemiology in this as well.
Absolutely. We'll make sure to bring an update on that. It's very early. We started planning, had 2 meetings because we recognized it, but it's something we're hoping to build and utilize the high-risk medical home groups, especially for patients that need that support because of their diagnosis.
The other thing I would like to toss out is, if we're looking at it and we're really trying to make an impact into the minority communities, in particular, into the African American and Latino community, can we do something to go out into the churches? Because the mothers and the daughters, well, mothers are the ones who are really suffering because they're always putting everyone's health before theirs. So we need to do something that will incentivize them to take care of themselves. And I think the Change Institute, first time I heard about it was fantastic, and it really sounds great. And my comments are just to give out some other ideas that maybe haven't been put on the table, how we can really make an impact. And breast cancer seems to be one that just doesn't seem to make sense to me. And I think we can do something about it, and you're definitely doing the parts to try to do something to help it out.
Okay.
So thank you.
Absolutely, we will do. And I know our county care team has done great inroads in working with our faith group leaders and others to be able to engage where we can explore how we can do more and then take the education and the support. So we'll definitely work with our team on that. Thank you.
Thank you. Thank you very much. Great report.
All right, well, that concludes my report. Any other questions?
Director, any additional questions for Mr. Rocha or his staff on any other items in this report?
Judge did a great job.
Yeah, that's great. I mean, thank you for sharing the update today on some of the specialty areas.
Yeah.
The one on dialysis, renal care previously was great, so we appreciate it. I think directors, I didn't have it. We are doing everything everywhere all at once. If you just think about the comprehensive of the report, to the staff and to the team, we recognize that. This is a lot that we're trying to do to actually accelerate this organization in a very positive way to impact the community. So we recognize that. And for those who just sat through all of these things, if you think of all the questions you're asking, this is all interrelated, right? And it's a challenge in doing it well, right? We recognize we're not going to always do excellent all the time, but we're going to continue to focus on improvement and doing it and engaging. So thank you. Thank you, directors. Thank you, staff. We really appreciate it. I'm surprised everybody. I don't think we're going into closed session today at all. You say why? We don't have anything. Yeah, we're not expecting any closed session. So we will not be going into closed session today. So if there are no other questions or matters to be discussed, can we move to adjourn the meeting?
So move.
Thank you. Do you think they're excited? The motion to adjourn has been made and seconded. Is there any discussions on the motion? No, thank you. I take that as a positive. All in favor? Aye. All opposed? Thank you. The ayes have it. The meeting is adjourned. Thank you all. We are cheery and